Good evening, ladies and gentlemen. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club and on behalf of members of Dubai Pediatric Club, I would like to welcome all of you from Dubai, UAE, GCC countries, and other countries, especially from the UK. We have a distinguished speaker, Dr. Santosh Mordekar from the UK. He's our guest speaker, and we'll have a distinguished panelist also. In a short while, I'll be introducing them. I would like to get your permission to share my screen. Is it okay, Mr. Tawfiq?
Yes, you can start the presentation, Doctor.
Yeah. So once again, good evening to all. Today's webinar is on pediatric neurology. And as I said, we have distinguished speaker and panelists. Our speaker is Dr. Santosh Mordekar from the UK. And our panelists are Dr. Aman Sohail, Dr. Sunny Phillips, and Dr. Manoj. In a short while, I'll be introducing them. We have also moderator Dr. Kalpana Sengupta and Dr. Rafia. Well, always I ask a question. This time, Mr. Tawfiq has promised to give a token of appreciation. We will announce the name of the winner. Who is this gentleman and why he is famous? You just write in the chat box and Mr. Tawfiq will announce. Well, a beautiful painting by Luke Field's doctor and the sick child. Child may be unconscious. Today, our speaker and panelists, they will discuss how to approach this type of children. Beautiful Dubai. As always, I say, one of the most beautiful and best cities in the world, and it's the best time of the year to come. And we have Expo 2020 also. Beautiful Dubai, view of Burj Al Arab and Sheikh Zayed Road. Members of Dubai Pediatric Club, members of the executive committee, as usual, Dr. Joshi, past president, Dr. Kalpana Sengupta, secretary, Dr. Diari, the chairman of Academic Affairs. Dr. Diari is in Latifa Hospital now. Dr. Amir Tolemat, Dr. Ayman Jundi, Dr. Rafia Overa, Dr. Bandari, Dr. Leila, and Dr. Khaled. Well, as I said, our speaker, first time he's presenting in Dubai Pediatric Club. I have already circulated the profile. In a short while, I'll introduce him, but other panelists are well known in Dubai and UAE. They don't need any introduction. Dr. Sunny Philip, Senior Consultant Pediatric Neurologist at Mediclinic City Hospital, Dubai. Dr. Aman Sohail, Consultant Pediatric Neurologist at Neopedia, Dubai. And Dr. Manoj Singh, Consultant Pediatric Neurologist at NMC Royal Sharjah NMC Specialty Hospital, Dubai. We have two moderators, well-known Dr. Kalpana Sengupta, Senior Specialist Pediatrician, Head of Department of Pediatric and Secretary of the Club, and Dr. Rafia Overa, Specialist Pediatrician at Jumeirah Clinic. She is the branch manager. She is member of Executive Committee. I would like to announce here that on 15th of October in Conrad Hotel, they have International Pediatric Conference. Dr. Joshi and Dr. Rafia, they are president of the conference. I would like to request all viewers to register and join. It is both virtual as well as physical. It is free for registration with very renowned speakers. Please don't forget. Well, I would like to give very briefly in 10 minutes the history of neurology and pediatric neurology. Pediatric neurology and neurology started from neuroanatomy, beautiful painting showing anatomy lessons by Rembrandt, is showing anatomy lessons of Dr. Tolb and Dr. Diekman, beautiful paintings, and of course advanced to the examination, detailed examination of the neurology always Hippocrates, and Hippocrates was the first to describe the seizure. He is always, that is why I always start in the memory of Hippocrates, the father of the medicine. Beautiful painting by Borlée. This gentleman is Jean-Martin Charcot, the father of neurology. Charcot is a student here, Babinski and Desjardins in France in 19th century, laid the foundation of the neurology. In this painting, you see Charcot demonstrating hypnosis on a hysterical lady, and on the wall also, if you see, there is a hysterical. At that time, because of this hysterical lady, is this Babinski. This is Babinski. Why he is famous? Babinski used to elicit with this feather, this sign. This was to distinguish hysterical from the organic. That is why Babinski became very famous. He was a student of Charcot, the father of neurology. Well, some of the pioneers of neurology in the Europe, you see Dr. Jackson here, and if you can identify, there are very famous neurologists in this gathering. I will just mention beautiful painting by Luc Peldes, a sick child. Father doesn't know what to do, unconscious. Today, our speaker and panelists, they will go to the detail of that and find out what is the cause. Well, child neurology was recognized as a board certified specialty only 40 years ago. But contribution to our understanding of the neurologic disorder of childhood has spent more than 100 years. See some of the pioneers. Batten is the father of pediatric neurology in Europe. Dubovich, Sack, Tay-Sack, Freud, Ford, and Kotter. They are the pioneers. Well, this is the question's answer. Bernard Sack is the father of pediatric neurology. So his name is associated with many conditions. Well, in England, Frederick Batten is known as the father of pediatric neurology. Frederick Batten made many major contributions to neurology and rehabilitation. Among many published work, his papers on familial cerebral degeneration with symmetrical changes in the macula, or maculae, that is called Batten's disease. Subacute combined degeneration of the cord and dystrophia myotonica, they are all associated with his name. This is that beautiful picture you see here, Jackson. This is Batten. You see other very famous, Gower, Turner, Tooth, Gunn. They are all their name associated with syndrome. We during our MBBS and MD reading, now you can see the pictures here. Now here you see Henry Gaston. He is known as the ambassador of the epilepsy by International League Against Epilepsy in 1968. Both together, William Lenners is a neurologist from Boston, United States, and Henry Gaston. Gaston, he is not pronounced in French. Both of them independently, they describe this condition, and now the condition known as Lenners-Gaston syndrome, very well known. So they are the pioneers, and this is Hans Berger, first described EEG in 1932. Well, let us remember some of the pioneers, at least in this field. Röntgen in X-ray. In 1895, he did X-ray on left hand of his wife. While sonography, you see here Hansfeld, CT scan, and Lutterbach, MRI. At least we should know their names. And Swayman, Kenneth Swayman, all pediatric neurologists are familiar. He has contributed a lot, and he has a very famous book also. The mother doesn't know what to do, really. Now, this is our neurologist and pediatrician to take a good history. But sometimes, especially mother goes so much in detail, the doctor forgets what was the complaint of the patient. And instead of patient, doctor gets headache and migraine. And here it reminds me of Vincent van Gogh. It is interesting to know this Van Gogh he had migraine and headache while drawing these pictures. This stroke on the drawing, this showing during the headache and migraine as well. And this is a screen by Edward Monk. Examination of neurology, very important. See, if they are in despair, parents, what to do. Only one person can help, our speaker, Dr. Santosh Mordekar. Tonight he will tell us everything. Dr. Santosh is a consultant pediatric neurologist since 2006. He is a clinical lead for intrathecal baclofen services, movement disorder, and spasticity services in children in the South Yorkshire, North Derbyshire, and North Lincolnshire region. Dr. Santosh has established multidisciplinary ITP clinics, specialist pediatric movement disorder clinics, and Tourette syndrome clinics in his region. It is the third largest IBT service for children in the UK. He was the linear advisor in pediatric neurology for Trent region and sat on the Council of British Pediatric Neurology Association from 2006 to 2012. Dr. Santosh was a registered stakeholder for the NICE guidelines for spasticity in children published in 2012. As a pediatric epilepsy trainer, he has been teaching on the PET courses for the last 15 years. Dr. Mordekar is the lead for the neuroscience module and for PGD Child Health University of Leeds since the last 5 years. He has been invited to give lecture internationally in India and Egypt with excellent remark. And tonight he will get excellent remark from the Dubai and UAE as well. Dr. Santosh is on the faculty of BPNA expert movement disorder course. Since the last 9 years, he is the medical expert panel of the advisor for the patient support group, Tourette Action UK. He is also on the medical expert panel of the advisor for the Ataxia UK and run a national specialist pediatric ataxia clinic in the UK. With this, I'm going to end. The father of neurology, Charcot, said, disease is very old and nothing about it has changed. It is we who change as we learn to recognize what was formerly imperceptible. And the father of medicine said it is more important to know a person rather than the disease. I mean, what is wrong with the person? Very good. I've told this quotation many times. Well, with this, these are my references. Beautiful Dubai. Once again, I invite you. With this, I end. Now, I would like to request Dr. Santosh to start his talk. I would like to request the viewer to write their questions. Over to Dr. Santosh. Dr. Santosh, please.
Thank you, Dr. Sora, for a very kind introduction. And I'm really delighted to be invited to speak at this forum. I'm sure, can you see my full screen? Just say yes, somebody.
Yes, doctor.
Thank you very much. So I'm going to talk about a diagnostic approach to a child with ataxia. So as Dr. Saurabh said, I do a lot of work with Ataxia UK, which is a patient support organization. And it's an excellent resource, not only for patients, but also for professionals, because on that website, which I'll give you at the end of my talk, we do a lot of investigations, what research is currently going on various types of chronic ataxias. It's a very up-to-date website, which is there. So what I was going to talk about was these things. So I've got about 40 to 45 minutes. So you can't cover the entire ataxia in 45 minutes. So I was going to outline my talk on definition of ataxia, a bit about anatomy of ataxia. Then we'll go into the causes and types of the etiology of ataxias, an investigative approach in those, each of them. And then at the end, I'll talk more about a clinical approach to a child with acute ataxias. And in between, as I go through, I'll tell you a few of the patients which I've seen through and their history, which is there. So what is ataxia? So ataxia is two words. So A and taxis. So A means without or lacking. Taxis means order or straightness. So anything which affects that, your order or straightness, that is ataxia. The definition is that it is an inability to make smooth, accurate, and coordinated movements. And it's usually due to a dysfunction of the cerebellum and due to its inputs and outputs which are there, and also the information it takes out of the cerebellum into the posterior columns of a spinal cord. So in cases of ataxia, when they're there is discoordination. The muscles are not weak, they're just discoordinated. So how common is ataxia? So if you look at the worldwide prevalence of ataxia in children, it's about 26 per 100,000. So if you want to put it in clinical context, it is rare, as cerebral palsy is about almost 10 times. So it's 211 per 100,000. And for autism, it's about 620 per 100,000. But you have to remember that acute ataxia is a very common presentation to emergency department and to general pediatricians, and it's got a range of causes, which will come in a minute. So if you look at this video, classic thing is the broad-based gait. When they turn around, that's the time you see that imbalance which happens. They lose a balance, they go back, and if you see them again. I'll run it on loop once more just to have a look at you. So when he turns around, that's the time it becomes a bit unsteady. So that's what happens with ataxia. Now, what happens usually in ataxia, it's just not purely cerebellum, it's usually a combination of the walls which is written out there. So it's the posterior spinocerebellar tracts, the cerebellum itself, and the combination of that usually leads to an ataxia. So I will talk about it slowly now, going through the anatomy of it. So this is the section of cerebellum. So on the left, what you have is you've got a superior view. So you're looking from the top, and on the right hand side, you've got an inferior view. And this is what the whole label of there. So you have in the center, you have got vermis, and then on the peripheries, you've got the cerebellar hemispheres. Now, if you want to distinguish function or understand what it is, you can divide it into three columns. You can have a functional region. To match it, you can have an anatomical region, and then you can tell us what motor function and what you will see clinically. So if you have a problem in the vestibulocerebellar system or cerebellum, the area which is there is foculonodular. So it's a bit of a vermis and the side next to it. And because it's central in origin, the problem is with balance, vestibular reflexes, so vestibular ataxia, and axial control. So you get poor axial control or axial hypotonia by the spinal cord. That's this thing. If you've got a spinocerebellar problems affected, then you've got a vermis and also the medial aspects of the both cerebellar hemispheres. So in them, what you have got is a problem with motor control and execution, essentially of the proximal muscles going to the distal muscles and the axial control. And that is where you will have a problem with dysdiadokinesias, tremors, all those things which you'll see. If you have got affection of purely cerebrocerebellum, that's a lateral cerebellar hemispheres, it's just not the movement, but it's a planning, execution, the executive functioning, the cognitive difficulties, they all will be there, which is called as a CCAS, which is a cerebral cognitive affective syndrome. So it's just not the thing to think about of movement problems. So if you look at the MRI scan, I mean, most of you will know about this, but if you look at MRI scan, on the left-hand side, what you have is you've got a very good cerebellar volume that is nicely from vermis, cerebellar hemispheres, and there is no problem there at all. But if you look at here, there is a vermis hypertrophy, and the same with cerebellum. So it's just shrunk. And there are various causes which will come in a minute with them. So what cerebellum was in the past sometimes thought to be very rudimentally a primitive part of a movement control, but increasingly now we know that it is a very large organ. So if you open up the folds of the cerebellum, the surface area which covers is approximately 75% of both cerebral cortex or cerebral hemispheres. So it is an extensive organ. And because it gets the inputs from the cerebral hemispheres and it processes information, so it's to do a lot of things with executive functioning, planning, organizing. And that's why these are the children, if they have this problem, they do not have much of a motor disability, but they have something called as a hidden disability. And they become more and more apparent and clearer when you go into your teenage years. And that's the time the gap between them and the peers increases. So you need to be aware of that conditions, and psychological or psychometric testing will clearly highlight this, and the psychologist or psychology experts will clearly pick this up. Also, most of you will know that in contrast to the cerebral hemispheres, the motor representation is on the same side. So if your right cerebral hemisphere is affected, you that right side is affected as opposed to the cerebral hemispheres. Okay, so how do you classify ataxia? There are various ways to classify ataxia. So you can classify anatomically, in which you can be either a cerebellar ataxia, that's a motor ataxia, or you can have a sensory ataxia. In cerebral, you can have a pure ataxia and complicated. Pure means just motor control problems, no cognitive problems, or you can have a combination of both. You can classify according to primary or secondary, and secondary means, I'll come into that in detail now, is as either because of an infection, vascular cause, tumor, etc., causing a cerebellar ataxia. Or you can have a primary ataxia in which it could be a whole range of genetic disorders which can cause a cerebellar ataxia or non-genetic causes. Or you can classify it with the time of presentation. So it's acute, subacute, or chronic. So there are various ways to classify ataxia. Now, how do you present? The presentation of ataxia is very diverse, and all of you will know that. So it can be transient, so it can happen following a viral infection or post-viral cereballitis. It quickly resolves and it goes away. You can have episodic, that means it comes and goes, and we'll talk a bit about how to look for them and investigate them. And that could be, some of them could be genetic causes, or you can have a progressive ataxias as it goes worse, and we'll come into those names of you. So a few to name are Friedreich's ataxias, spinocerebellar ataxias, ataxia telangiectasias, etc. How do you look out for them? Is there anything which can point to you in your history taking about them? So there are various things which you can have. So if you have got a presentation, you start thinking of a potential etiology. So if you've got somebody with headache, temporal, you're thinking of in your mind, the history is targeted towards either it's a basilar migraine, is it a space occupying lesion, or a tumor? And that's the localization on the right hand side, which I've tried to say. So if you've got an acute onset, unsupervised toddler who comes with ataxia, the first thing you'll think about is toxicology, or possibly following a fall, so concussion or anything. So you are looking at the investigations planning will be accordingly urine and blood toxicology, MRI, brain, vascular, MR angiography for strokes, etc. If they come with intermittent vomiting, so you need to think, so benign paroxysmal vertigo, basilar migraine, strokes, concussions, it's very common to see those, and you'll have to probe the history into that. If you've got recent history of viral gastroenteritis, then you're thinking of post-infectious causes like your ADEM, post-infectious cereballitis, all the autoimmune causes, so Kawasaki's, henoch-Schönlein purpura, which we had just 2 weeks back at our patient who came in with acute onset ataxia, was found to have henoch-Schönlein purpura. If there's a recent immunization, then you'll think of, again, para-infectious like Guillain-Barré syndrome, any other post-infectious ataxias. So you will have those things, you're going to look out for it, and you're trying to understand where exactly the problem is, so that you plan your clinical assessment of them. So similarly, if you've got a nystagmus, you're going to think about any abnormal eye movements of paroxysmal vertigo, nystagmus, a neuroblastoma like an oxyclonus myoclonus, any kind of stroke which is there. Don't forget seizures. They can cause post-ictal ataxia. I'll tell you a bit about my patient. Can present non-convulsive status epilepticus who can present with ataxias. We have had a few of them. Fluctuating drug levels again can cause ataxia. A child who is on a regular treatment of an anti-epileptic medication and suddenly gets a double dose or something happens, they are on a very high dose, and an antibiotic like a macrolide is given, and that just pushes up the drug levels beyond that, and you can get an ataxia. So be aware of those things. Acute onset encephalopathy can present be ADEM or a first onset of MS, or again, toxicologies. So these are the things you're going to think about when you're trying to look into it. So when I'm looking at a child with ataxia, these are the things in my mind when I'm asking the history to the patient. I've just covered this about, so you think about what are the symptoms. These are the ones which could be dizziness, could be a sign of an ataxia, because people cause dizziness very loosely. So when somebody says, I'm dizzy, I feel dizzy, I ask them, what do you mean by dizzy? Are you spinning around? Is the room spinning around you? So I try to understand what they mean by the word dizziness, because it could be a sign of labyrinthitis and presenting as an ataxia. And then if you've got any chronic causes of ataxia, positive family history or something might help you, or it might not help you. Longer duration, how is it evolving? That also helps you. Okay, so let's start now looking at the causes. So if you have somebody comes in with acute ataxias, so first cause could be an infection. So amongst infection, you've got whole lots of them. You can have post-viral, cerebellar abscess, cerebellitis, tuberculosis, any immunizations, labyrinthitis. Any of these can lead to an acute onset ataxias. So this is one of my patients who was about 3.5 to 4 years of age, had a bit of a diarrhea, not anything to write reports about, quickly resolved, but quickly started becoming ataxic, was a bit altered, and came into A&E. And as he came in, because he was an acute onset ataxia, the scan was done. This is what the scan showed. So there was a swelling, if you look at it, was just around the vermis, bilaterally the hemispheres were affected. And increasingly, it was noticed that, and his stool culture came for enterovirus positive, and he had become mute. So he stopped speaking. So his non-verbal communication was quite good, but he had this medical mutism. So cerebellum mutism is again very well recognized, and he lost his speech, but he could respond non-verbally. If you ask him, where is your mom, where is your dad, he could be able to point it. So there was not much of the sensorium had improved, and you will see such patients. And the natural history of cerebellum medical causes of mutism usually is that in about 6 months' time, about 70 to 80% of the speech comes back. 10 to 20% can be left with dysarthria, but the speech slowly came back. And this boy, about 4 to 6 weeks, he started speaking single words. By 3 months, he was speaking almost sentences, and by 6 months, he was speaking lots of, back to what he was before. But there was slight dysarthria, which was again worse in the evening. So be aware of that. Para-infectious causes, do not forget ADEM, transverse myelitis, so acute disseminated encephalomyelitis, acute transverse myelitis, Guillain-Barré, Miller-Fisher syndrome, which is ophthalmoplegia with Guillain-Barré, and Bickerstaff encephalitis, which is again a central demyelination cause. All of them can present with acute onset ataxia. So this is one of my patients this is a few years back now. He came in following a viral infections, and he was encephalopathic. He came in and he did not have a seizure, but his PCS was low, and we had a quick MRI done, and you can see that he had T2 weighted signal changes, which showed that he had multiple high signal changes in the range of vision, which was typical of ADEM. And once we had investigated and ruled causes of an infection, we gave him a course of steroid, and he improved quite well. In terms of ADEM, again, there are different ranges of steroids which are used. There is no particular regime. So some people use a high dose IV methylprednisolone for 3 to 5 days and stop. Some people use that and then give a prolonged course for 3 to 4 weeks and then taper it down. And some people use dexamethasone. If the child is not very bad, some people have also used oral methylprednisolone. So there's a range of them. And what you do is that once the child had made a recovery, you usually repeat an MRI scan in 3 to 6 months to ensure that the scans have improved, and then you follow the children up. Intoxication, again, don't forget about urine toxicologies and blood toxicologies. There's a whole range of practically any drug in high doses might be able to cause ataxia. If you look at them, quite a few anti-epileptic medications causes ataxias. So you have to be careful about them. So any child in our hospital, when they come with an acute ataxia, they all get drug and urine sent for them. So because I've made a guideline, so it will happen immediately when they come to our A&E department or our general pediatrician. So be aware of them. Vascular causes, again, any kind of basilar migraine, cerebellar embolism, strokes, any of these can present with ataxia. So please be aware of it. So that's why neuroimaging is very important. Tumors, so a range of tumors, so any kind of cerebellar space-occupying lesions, so medulloblastomas, astrocytomas, neuroblastomas, or spinal cord tumors can present. I'll show you a video of one of my patients who was referred to me and look at the eye movements. So he had this chaotic eye movements, this is called oxyclonus, and he also had myoclonus. He became very irritable. We did the investigation. It was found to have a neuroblastoma. It was confirmed. He had a course of steroid which improved, and luckily that steroid, just a single course of steroid, kept him into remission. However, some of these cases need immunosuppression in the form of rituximab or some other immunosuppression in the longer term regime. So you need those as well. And just recently we have finished a European trial for oxyclonus myoclonus, and shortly the results should be published soon. The last, one of the next causes is epileptic. So don't forget epilepsy or non-convulsive status epilepticus. So this is again one of the EEGs of one of my patients, and she used to go into this intermittent non-convulsive status epilepticus, and she used to come out of it. So she used to, during the period of that, she used to be ataxic, slightly a bit confused, but she could still speak, she could still walk, a bit unsteady. And by the time she used to come to hospital, she used to get this kind of an EEG. So it's important that when she used to be there, she used to be in a few hours in this. So we arranged for an urgent EEG, and we found that she was in non-convulsive status. And if you treat, it can be there. So one of them could be a non-convulsive status epilepticus, could be a presentation of ataxias. And then last not the least, so psychogenic or unexplained, be aware of that. They also can present with ataxia. The next video, which is, it's not my video, it's a video from YouTube, which was there, which I picked it up. So if you see that, the movement, even though it's a broad-based gait, there's a too much of, it's not an axial hypotonia, it's more of movement, which is very clear that this is not that of a classic ataxias. I have got lots of videos of ataxic children, but I do not have the consenting for them to be shown on a forum. I've got only for showing it in my colleagues. So because that's why I can't show you. But this is not a classic case of an ataxia if you see them. Okay. So what about intermittent ataxia? That's it goes and goes away. So in those ones, episodic ataxias are common, and they can be either EA1, which is a potassium channelopathy, or they can have a EA2, that's episodic ataxia type 2, which is a calcium channelopathy. If you look at them, the presentation is quite diverse. So because I do the National Ataxia Clinic, I've got quite a few of patients of both of them. So the EA1, they can present in newborns as a stiff baby or neonatal hypertonia. It's not common, but it's one of the things to think of if you have them. They can also present with sometimes focal epilepsy, and one of them was picked up who had a focal epilepsy, and he was a bit unsteady, and over ataxia gene panel they picked up the diagnosis. The EA2 ones are the ones which have again got a presentation of, because it's the same gene which can cause complicated migraine, hemiplegic migraine. So you can present them, and I've got quite a few of EA2 ones. They respond quite well to, because they're channelopathies, to either acetazolamide. They can also quite well respond to flunarizine, and some of them with 4-aminodipyridine also can be, they can respond to in medication if they're causing difficulty in quality of life. Do not forget GLUT1 deficiencies, because they usually are well known to cause intractable epilepsies, microcephaly, but movement disorder or an unexplained movement disorder in the first 1 to 2 years life, there should be a differential diagnosis, because if ketogenic diet is offered early, there's a good outcome. The diagnosis, which you all will know, it can be now genetically picked up, or you can pick it up by doing a CSF glucose with a paired plasma glucose, and you can make a diagnosis. There are newer drugs like fenfluramine and all available. I can't cover everything in one go, but please remember GLUT1 deficiency. Do not forget, as it's a treatable cause. Metabolic causes also are quite present, can cause presentation of ataxia. So you can have maple syrup urine disease, urea cycle defects, biotinidase deficiency. I've got 2 patients of biotinidase deficiency who presented with ataxia. Again, a treatable cause. So high dose biotin will be helpful. Vitamin E deficiency, which I'll speak in a minute, it's again important cause of a treatable ataxia. Pyridase dehydrogenase deficiency, pyruvate decarboxylase, and it's as simple as hypoglycemia also can cause ataxia. So you need to think about that. If they have it, please check the blood glucose, and simple thing might get your diagnosis. Epileptic we talked about, that's non-convulsive status epilepticus and ESUS, and psychogenic we talked about. So these can present with intermittent ataxias as well. What about chronic ataxias? Now, chronic ataxias, they can be hereditary ataxias, which could be either autosomal dominant or autosomal recessive. You have to remember, which I'll talk about a little bit, they are not very common in the pediatric age group, apart from a few which I'll talk in a minute. So you can have autosomal dominant, which could be spinocerebellar ataxias. A positive could be even episodic ataxias. HSP, so hereditary spastic paraparesis, can present with ataxias. Please don't forget that. So we have got a gene panel in Sheffield we used to do, which is stopped now because from 1st of July, everything is genomic sequencing now. But Sheffield had a gene panel which we used to look out for 170, 170 conditions with ataxia, and we had the largest gene panel. And we used to pick up a few, and I'll tell you what our results with that pickup rate was. You can have autosomal recessive. In that you have the spinocerebellar ataxias, Friedreich's ataxias, ataxia telangiectasias, and then the ataxia oculomotor apraxia type 1 and oculomotor apraxia type 2. So amongst that, the spinocerebellar ataxias are not very common in the pediatric age group, but they're very common in the adult onset age group. So adults see a lot of the spinocerebellar ataxias, except a few scars like scar 7 or scar 3. So if you look at this autosomal recessive cerebellar ataxias, which actually present in pediatric population, these are the ones we are going to see them. So, and the next we have, so you can get Friedreich's ataxia because of the frataxin gene. Then you have got the AOA1, which is the APT gene, or the SET2 gene, which is the synataxin or the apraxitine gene. And then the ataxia telangiectasia, which is the ATM gene, and then the ataxia telangiectasia-like disease, which is the HMRE11 gene. And if you look at them, the mean ages, most of them, they present at this age. So sometimes they can be escaping the pediatric population, and they might be seen by adult onset group. However, increasingly, the phenotype as Friedreich's has now got really good now, and people have started recognizing it early onset now. And if you look at them, oculomotor apraxia is only common in these two. The coriform movements is only common in these two, the AOA1s and AOA2. And there's no good treatment for them, but I've found sometimes tetrabenazine, a dopamine depleting agent, can help you to slow down. And there are some promising results from US now with a deutetrabenazine, which has been used for coriform movements. So I haven't tried them because it's still not available in Europe. And then you see the neuropathy is a bit common presentations with both of them because of the spinocerebellar involvement. And then you get all the things which are there. So these are the ones which are commonly going to see there. White matter disorder, so leukodystrophies can present with an ataxias, and I've picked up a few. So I've got a hypomyelination child who was found to have MCT8 deficiency with Allen-Herndon-Dudley syndrome, a boy who was first referred to me as a dyspraxia, but he clearly had ataxia, and on our gene panel we found to have an MCT8 diagnosis, so they can present with ataxia. I've got about a few cocaine syndrome patients under me which I've picked them up. So they've got a classic phenotype in which that they are very vulnerable to any kind of sunlight, so they get the skin hypersensitivity, so you can pick up on that, so you can get those, and a whole lot of mitochondrial disorders can present with ataxias. So I've got a few vanishing white matter disease who presented with an ataxia, which I'm following up, and it's a very progressive condition, which you know. And one of my PhD student is now looking into a stress response in this specific group of patients. Vitamin D deficiencies, do not forget, they're treatable. So in our hospital, when they came, I usually try and give a vitamin cocktail presentation, vitamin supplements. I do the levels and get it done. So amongst them, don't forget B6, B12 can present with an ataxia. It can be seen in people who are sometimes recently gone into vegan, which is popular now all over the world. So they don't have any source of vitamin B12, and they can present with ataxia, and they got white matter disorders, and you can easily pick up with vitamin B12 levels or urine for methylmalonic acid. And then vitamin E, do not forget I said vitamin E deficiency because the presentation is like Friedreich's ataxia, but there is no cardiomyopathy. They have got this classic titubation of the head tremor, which is saying no. So it's horizontal tremor, they have got it. They can go on to progress to got retinopathy, deafness, dystonia, and bladder. It's a treatable cause. If you do vitamin E levels, we'll make a diagnosis. You can even genetically diagnose them. Because it's a fat-soluble vitamin, it might not present to us. It might present to our gastroenterology colleagues with malabsorption syndromes, or CF, etc. So you have to be aware of it. And doing a level and early treatment definitely has got good outcomes. Then you've got sensory ataxias, which have sensory causes which are there. So you can have Repsum disease, Canavan's disease, Cocaine's. Again, I said biotinidase deficiencies, vitamin E, so treatable causes. So be aware of those. Tumor, we have already spoken about, and we have talked about epileptic, and again, psychogenic. Do not forget that that can present in any form of them. It just might not be picked up. So please be aware of that. Okay, so we have got through the causes now. So what are the differential diagnoses of ataxias? Now, how do you rate them? So there are different rating scales. So one of the brief rating scales, bars, is the one which is a 5 items rating scale, and each has got 6 points into that. And so you can get a 30-point score. The lower the score, the better. Higher the score, worse the ataxia. Then there is SARA, which is scale of assessment of rating and ataxia, which is what I use for monitoring the progression of ataxia, which I'll show it in a bit. And the last two, the ICARS, and the modified ACARS, are a very detailed score in 100-point and 120-point scores, looking at about 16 or 19 items. It is very difficult to run that in a busy clinic, which we have it. So it needs usually to be run by a therapist, or if you've got more time. So this is SARA. So I wouldn't, please, I'm sorry about the details. So it is available. So if you Google it, the PDF version is available on it. And what you have is, what you have is a name of the rater. You can put a date on, you can put the patient's name on, and there are these 8 domains which are, so the gait, stance, sitting, speech disturbance, finger chase, finger nose test, which you always do, fast alternating hand movements for dysdiadochidesia, and then a heel shin slide. So it tells you exactly what to do, and you have to do it. So initially it takes time, but once you're very aware of it, it's very easy to know. So you have to do them, and the lower scores, all the 0 scores, are the normal, and the higher scores is the one which gives the outcome. So speech disturbance, looking for dysarthria. So if you look at the dyspraxia or something, you might get this problems here, but the speech is spot on. So sometimes it is very difficult. There have been a lot of studies have been done on the utility of SARAs, and they have been published in developmental medicine and child neurology. So I find that it is more reliable after 8 or 9 years of age. In the younger children, you have to use it with caution. And then what I do is that every time they come in my national ataxia clinic, they get this, and it helps me to understand the progression of the disease. Has the child got worse or not when I compare it with the previous years? It has got some observer variability, because what I give 1 or 2, if you give 2 or 3, there might be slight deterioration which will be there. But usually, if the team which I have got, they're pretty much trained by me, so they do pretty much the scoring system is not that badly affected. So how do you investigate a child with ataxias? So if you're investigating the first line in all children with ataxia, the second line you'll have to just program your investigation. So as a first line, what you will need is, because you want to rule out tumor or space coagulation, all of them will need the MRI brain and plus or minus spine, depending on your findings. You need MR spectroscopy, MR angiography, and if it's not available in the region, at least CT to rule out a space lesion. Increasingly at Sheffield, because we're doing a lot of research on children with ataxia, we are trying to find and identifying a biomarker if we can find. So we are looking at MR spectroscopy specifically in the cerebellum. So MR spectroscopy is something like looking at the chemicals in your brain, and you're looking at N-acetyl acetate cysteine peak, creatinine peak. So you're looking at one as a cerebellum, and one you are looking at the cerebellar hemispheres. So at the moment in the published literature, we do not have pediatric levels. We have only about adult levels. So we have just about to publish what are the normograms in next month or so for the each age specification, so it can help us to know what the abnormal levels are. So this is the one which is in Burmese, and that the other voxel which you take it is in the cerebellar hemispheres. And we've got pretty much understanding now what are the normal levels in a child from 1 year of age or 2 years old till 16 years of age. And they're different from the adult levels, and you cannot rely on the adult levels to use as an identifying marker for looking at the progression of them. So in my clinic, all of these children, they get annual scans by MR spectroscopy to see the progression of the chronic ataxias. So the other thing which you want to look out for when you investigate, if the child is presenting with encephalopathy, so along with we talked about urine and blood toxicology, you look at infective causes, you'll look out for EEG for non-convulsive status epilepticus. If they're not encephalopathic, you're going to look out for peripheral causes like Guillain-Barré syndrome, neuropathy causes, all those things. So you'll work your things about it. If it's a metabolic cause, you're going to look out for urine organic acids, ammonias, plasma amino acids. If it's purely sensory, you're looking mostly towards Guillain-Barré syndrome, looking at anti-GM1, anti-GQ1B antibodies, stool cultures, looking for Clostridium jejuni, etc., depending on what your presentation is. If it's intermittent ataxias, increasingly now, genetic testing has taken over. So we usually, in my patient, they all used to get this gene panel for looking at the ataxia gene panel, but now it's been replaced by the genomic sequencing, which you have got a specific R number, and some of you must be aware of those. So we have got specific R numbers for hereditary ataxias, non-hereditary ataxias, all the numbers which are there, and we get the results in them. Urine toxicology for, again, intermittent ataxias is very important because you could get your answers. If it's a toxicology, again, organic acids, if they're encephalopathic coming in, you might pick up any of the metabolic causes. And as I said, these are the ones for GLUT1, do not forget those, and for non-convulsive status. If it's chronic ataxias, I think it depends on the history and clinical presentation. In the UK, these investigations are specifically taken by tertiary pediatric neurologists. There is a whole load of investigations, so you'll have to titrate your investigation. They're all expensive. So if you get any markers from the neuroimaging, we have got very experienced neuroradiologists. They also guide us in planning the investigation. But these are some of them which are there. We try and bring them in and try and arrange all of them in one go. If you're going to do a general anesthetic, I'll try and do the tissue biopsies and all the things in one go. I've just put this. This is one of the things when we published a paper on ataxia. I've just cut paste from that. So these are just the causes which you have talked about. So vitamin E supplements, what are these? Biotin responsive, biotinidase deficiencies, which are there. All these ones, the mitochondrial coenzyme Q10 is given. There is not much long-term studies undertaken. So if you've got PDH deficiency, as I said, ketogenic diet possibly helps, dichloroacetate helps, and all these things which are there. So some of them which can help, some of them are metabolic causes. You need to involve your metabolic colleagues and they can help you in understanding them. This was one of the studies which was undertaken by my PhD students, and we're just about to publish this. So what we wanted to look out for was the genetic diagnostic rates in children with pediatric ataxias. So because we had a lot of referrals coming from the whole of England, we tried to look at, so it's very difficult to read, but I'll summarize what it says. We tried to look at all the referrals which came for ataxia gene panel who had ataxia as a presenting symptom. So there were more than 700 referrals over the last 10 years. And if you look at them, which is what I had said, the commonest presentation was Friedreich's ataxia. So CSCN1A type 1A, so episodic ataxia type 2. And then we had got HSP. and then ATM, that's ataxia telangiectasias. Now this could be a quite slightly skewed because Birmingham, Malcolm Taylor's team also does the investigations, so some of them might go to him. So this is a bit slightly skewed, but rest of them, if you see, the numbers are very small, and still about 25 to 30% of them in pediatric ataxias are still undiagnosed, and there is no gene found. But increasingly, hopefully with the genomic sequencing, the numbers might change. So when you want to bring this all together, how are you going to try and understand this, and how are you going to get it all together? So what you are going to have, if a child comes out with you with an acute ataxia, so what are the things you're going to look out? So what we said was you're going to look out in the history if you can find out if there's a fever, if there is an acute onset lethargy, confusion, irritability, if there's been ear pain, discharge, if there's been a presentation of seizures or head injury. So that's things which is going to go in your mind. So whenever somebody calls me, because I cover on call a wide range of regions in South Yorkshire, Northeast Lincolnshire, when they call me, this is what is in my mind. So this is the question I ask: is there a presentation with fever, lethargy? If it's there, we said the first thing we're going to do is a neuroimaging, because we want to rule out if there's a tumor or not. If it's an acute onset ataxia, again, urine toxicology or blood toxicology to make sure that nothing has, increasing. Sometimes there is no history. You're going to ask the family, is there a history of some, a child could get an access of some tablets, which was one of the parents or grandmothers or grandfathers. You're going to send off a therapeutic drug levels, because I've seen a few times that people who are on a medication on a very high dose or high levels, for some reason, for intractable epilepsy, they get an antibiotic, which is bacteriostatic antibiotic for, hepatostatic antibiotic like clarithromycin or erythromycin, that just tips over the levels of carbamazepine. Suddenly you get an ataxia, and then that's the cause, and then you can work around by reducing the carbamazepine. Child quickly improves. If there is a history of that, this is your differential diagnosis in your mind. So it could be labyrinthitis. I've seen a few cases with labyrinthitis, and they do improve, but they take a bit longer time to improve. You can have an ADEM, an acute disseminated encephalopathy, a worsening of MS can bear a child who's got a stroke, especially cerebellar strokes, which present with dizziness and ataxia. In them, there's not much of a weakness, or it could be a cerebellar concussion or a cerebellitis. If it's not there in the history, what you're trying to think in your physical examination, I'm going to look out for these signs. So if there is a sign with poor gag, voice change, is it ascending weakness? Is it a facial weakness? Is there an areflexia? In my mind, I'm now thinking about like a Guillain-Barré syndrome. Is there a previous history of some recent immunization? So I'm going to think about that. And that's what is going to make me think about. If it is there, this is my differential diagnosis going to be. So is it stroke, ADEM, GBS, Miller-Fisher? So then accordingly, I can plan my investigations. Accordingly, I can plan, which other, colleagues support I need. So if it's GBS, which is worsening with the sound, which is worsening with peak flow, or is breathing is worsening, then I'm going to think about that. He might need support with airway. So he might need to be closer to a high dependency unit or a PICU, etc. That's what I'm going to think about. If it's still not there, then you're going to think about post-infectious cerebellitis. So it's not, again, uncommon. So you have somebody with chickenpox, the scabs have gone, and suddenly child becomes ataxic. And then if you scan them, you will find out there is some cerebellar swelling, but they are cognitively, GCS is completely 15, and that again slowly improves. If you've got somebody with a similar presentation in the past, which means an intermittent presentation, then you're going to think about, again, which we said about basilar migraine, episodic ataxia, BPV. Again, don't forget non-convulsive status epilepticus. Don't forget toxicology, neurometabolic causes, because intermittently in a crisis, they might be abnormal, but when they're in between them, the results might be normal. So you might, that time, think about ammonia levels. You need to think about that. You might get a diagnosis there. All these cases with intermittent ataxias, all these people who are there with you, they need follow-up, they need investigations, and depending on what your results come, you need to find out. So if you find somebody with, say, ADEM, stroke, you need to have a repeat imaging if indicated, even though the child has made improvement. We have had patients who presented with an acute onset ataxia. We did think it was an ADEM. We gave treatment with steroid, it improved. Sadly, it was not. It was a tumor. It was a glioblastoma multiforme. When they repeated the scan, immediately they came back. And so you have to have a repeat MRI scanning if you're thinking of demyelination, depending clinically how the child is done. If the child represents it early, you have to think about it. I always feel that pediatric neurology referral to your pediatric neurologist is very helpful early on, so you can plan the investigations well ahead of time, and you can do it so the child doesn't need repeated needles and planning it. So in our region, there is there's a guideline of ataxia which is there, which is in all our district general hospital. So our pediatric neurologist, me and my colleagues get called when a child presents with ataxia. They'll be managed quickly. The scan will be done. If the scan shows something, they will call us. If the scan comes normal, so they will call us, and then we'll plan investigations together. And that is the way we have been doing it. So summarizing up, because I know I'm running a few minutes late possibly. So if you have an acute ataxia, first thing you need to rule out is space-occupying lesion. You need to think of neuroblastoma if they're atypical features. If you find anything on the MRI scans, we talked about what the differential diagnosis could be. If you're keeping them, you're thinking either they are infectious, para-infectious, vascular, intoxication. This is the thing which is going to go in your mind, but slowly, that's a differential diagnosis, which is going to help you plan investigation. Intermittent ataxias still are underdiagnosed because they sometimes present and make a quick recovery themselves. You have to remember them because there are some treatable causes, and we can treat them. So we need to be aware of them. That's the reason I gave you a broad information about them. Look out for them. In terms of chronic ataxias, the commonest one in the pediatric age groups are Friedreich's ataxias, ataxia-telangiectasias, and AOA1 and AOA2. Rest of them are rare. I see them because I do a combined clinic with adult neurologists, so I see them later on. So some of these patients, interestingly, have not much presentation in the pediatric age group at all, but they start presenting with some clumsiness, falls at 16, 17 years of age, and they're progressively worn. So by 20, 25 years of age, they start getting the diagnosis. So that's why we can miss them unless there is a positive family history. And I always feel that the history, evolution of presentation, and careful planning of investigation is a very key to diagnosis. And finally, because I do a lot of work with Ataxia UK, I would suggest you visit this website. This is the page of that. There's a lot of information there available for newly diagnosed ataxia, for health professionals, even for patients, how to live with ataxia, what are the problems with them. So that covers importance of occupational therapists, what current research is going on in all the ataxias, which is very up to date. And it's regularly updated. And in the healthcare professionals column, there are all the investigations, what you need to do. Some of them we have updated. We have just recently updated. I've updated the pediatric part recently. So what are the things which are there? And they get regularly. So we have got ataxia medical experts meeting every 2 months, and we decide what is to be done and how whether so information about COVID and ataxias, what is need to be done. So it's all there, and you can download it, you can read through it, and hopefully that will be helpful. I'll stop over there, and thank you very much.
Thank you very much, Dr. Santosh, for this excellent detailed presentation. There are a lot of questions. I'm sure there will be a very good discussion tonight. Thank you very much. Now I would like to request Dr. Sunny Philip, one of the senior consultant pediatric neurologists who was also a teacher in the UK, to start this talk. Dr. Sunny is presenting a brief short case. I would like to request Dr. Sunny, please.
Thank you so much, Dr. Sharp, and thank you for the opportunity. Just going to share my slides. Can you see my slides?
Yes, please.
So once again, thank you, Dr. Sharp. It's an excellent opportunity with this forum to reach across to a large number of pediatricians and pediatric neurology colleagues as a way of networking and presenting an education. We've had an excellent presentation from Dr. Modekar about ataxia, and I'm just going to follow that with a child who had a presentation with ataxia and weakness, just to exemplify the common presentations of the causes of ataxia. So this is a 13-year-old child I've seen very recently in May. She presented with an onset of acute gait disorder with weakness on the left-hand side for arms and legs and heaviness over the last 2 weeks. She didn't complain of numbness or pain, and also didn't complain about slurred speech. There was no change in her behavior or her cognitive profile. She'd had these symptoms for about 5 days and it got better. So she didn't report that to medical professionals. And then it appeared again. That's the time she presented. And when I took the history, I got the history that she had a very similar episode 6 months ago in January, where she presented with milder symptoms with numbness of the left side of the cheek and headache. And she was at that time taken to the emergency department, had a CT scan, which was done, which was normal. And of course, as the symptoms were persisting at that time, she had MRI scan, which showed some changes in the brain, posteriorly, both on the right side and the left side, with increased signal with some mild dilatation of the posterior horn of the lateral ventricle. And that was diagnosed at that time as stroke, putting together with the symptoms of mild numbness on the cheek. And she had an extensive stroke workup with thrombophilia screen, protein S, protein C, fibrinogen, homocysteine, anticardiolipin antibodies. They were all negative. She also had a cardiological assessment in case it was thrombotic or embolic, and that was normal. So there were these two presentations which happened. Her birth history and postnatal history was unremarkable, and she was developmentally normal. So when I examined her, she had a very mild degree of upper motor neuron type of facial nerve palsy, particularly affecting the lower part of the left side of the face. And she was very unsteady, but her unsteadiness was unilateral. It was more swaying to the left. So she was quite ataxic and she couldn't walk straight, but she was constantly swaying and sort of leaning over to the left side. She had Romberg's negative, which indicated that she didn't have sensory ataxia. And she had finger nose ataxia again on the left side. So I was getting a lot of localizing signs in that she was ataxic, but she also had weakness, and all the signs were pointing towards the left side of her body, which was interesting. She had patchy weakness in the shoulder abductors and hip flexors, and these were flexor type of weakness, which indicated that it was an upper motor neuron type of lesion. Very mild weakness, power was 4+, and the reflexes were dampened, planters were downgoing. Her sensory examination was normal. So in a child who presents like this, with an acute gait problem, and of course she had a previous history with the symptoms and the focal neurological signs, as Dr. Santosh was pointing out, one of the first things you do is neuroimaging, because you want to rule out an acute symptomatic presentation, which could be space-occupying lesion, demyelination, stroke, many different causes. So it's quite an elegant investigation to do. So we did the scan. I've just put some pictures up of the scan. As you can notice, this is the cerebellum, as Dr. Santosh was pointing out. And very quickly, as I'm looking at the pointer, she has a lesion in the cerebral peduncle, but also in the brain stem connected to that. She didn't just have that, she had some high signal changes on the left side of the brain in the periventricular region and also on the right side. And you can see that very clearly in the FLAIR images here on the left and the right. She also had some additional white little changes in the left side. This image, you can see this was the old image. In January, it had this lesion on the left side and some on the right side. It was clear when I compared both the scans that some of the lesions were present before and some of the lesions were new on the presentation when I had seen her. So when you've got a child who presents in such a state with 2 episodes, who's got weakness, who's got changes, and of course, she had changes in the parietal region, which was giving rise to the weakness she had, or the numbness in the sense because of the sensory weakness. You do a range of investigations following the MRI scans to exclude the various causes which can give rise to changes which we are seeing in the brain. One of the most commonest things you think about is, of course, demyelination, especially when you're seeing these lesions both in the supratentorial and the infratentorial compartment. And we did her CSF, we did a whole lot of blood studies, which were all normal. And we did CSF to look for oligoclonal bands, which is to look for synthesis of antibodies within the CSF, and 2 oligoclonal bands were positive, indicating synthesis within the CSF. And we did neurofilament light chain, which is also a very sensitive test to look at antibody production within the neuroaxis, and that was markedly elevated. So these 2, combined with the neuroimaging changes and the history of 2 episodes, gave us the diagnosis of multiple sclerosis. The diagnosis of multiple sclerosis, as I will show in the following slides, can only be achieved when you have 2 or more episodes with additional neuroimaging signs and possibly evidence of CSF synthesis of antibodies. So we gave her acute treatment with IV methylprednisolone for 5 days, and then I tapered her with oral prednisolone for about 6 weeks and sent her to the rehabilitation team, and she was making recovery. But with the tapering of the steroids, she was presenting again and again with new signs or exacerbation of signs multiple times. About 4 times she presented, which led me to believe that this is a much more fulminant presentation. So I had to put her on disease-modifying agents. And now, as I'll tell you, disease-modifying agents have changed quite significantly from injectables to oral, looking at the child's age and ease of ability to deliver and the efficacy of this. I chose fingolimod, which is an oral agent, which is quite easy to give and well tolerated. And she's been on that for 2 months, and she's had no further relapses. The neurological examination is back to normal, and she is quite stable. Of course, this is a very early time, and the disease-modifying agents are really only to prevent significant relapses. It never guarantees that it won't happen again. So the presentation of my child is, of course, that of pediatric onset multiple sclerosis. It's a chronic demyelinating disease of the CNS of autoimmune origin. It is quite rare presentation, incidence being 0.07 to 2.9 per 100,000 children. And the diagnosis is made by 2 key elements. One is evidence of dissemination of inflammatory activity within the CNS on more than 1 location. And as you can see in this case, there were multiple CNS inflammatory plaques, which are visible both in the cerebellum and cerebellum supratentorially and infratentorially. And then, of course, the recurrent disease over time, which is dissemination in time. Again, in this child, there were 2 distinct episodes in January and May, and then further episodes following that. So that satisfied what we now call the Mcdonald Criteria 2017, which is an improvement on the Mcdonald Criteria 2010, which are diagnostic criteria used widely for diagnosis of MS. And essentially summing it down, you need to have at least 2 independent clinical attacks, 2 or more lesions which are disseminated in time and space, or 1 attack, 2 lesions, and the presence of CSF antibodies like oligoclonal bands or neurofilament light. MS presents in children and adults in different ways. So the child I'm just presenting was relapsing remitting type of MS. You can have primary progressive, in which there is a slow progression right from the beginning. You can have secondary progressive. That means that you begin as relapsing and remitting, and every time you have a relapse, the condition of the child worsens and you never achieve baseline. And then you can have progressive relapsing, which is the most fulminant presentation of MS. Now, the biggest change which has happened in demyelinating diseases is the progress in therapy. For a very long time, there was hardly any therapy except for treating of acute inflammatory episodes or relapses with steroids. And then interferons were introduced about 10 to 12 years ago, or about 15 years ago. And the primary therapy was IV injectables, which were Capaxon or interferon beta 1 and beta 2 for a very long time. For the last 5 years or so, other oral therapies have come into play, which are much easier to deliver and better tolerated. Tecfidera, Gilenya, which is fingolimod, which I used in this child, teriflunomide, and now certain infusions are also available for more aggressive disease like Lemtrada, Tysarbi, Novatron. So there's a plethora of agents we can use in young children as well as adults. Many of them, unfortunately, are not licensed for children. There are only limited number which are licensed in children, which limits our therapeutic ability in young children, but adults, of course, they're all licensed. This is a simple algorithm looking at treatment of rapidly remitting multiple sclerosis. You can divide them as moderately active disease, highly active disease, or rapidly evolving disease. With the moderately active disease, it's mainly interferon or Capaxon, which I had shown you before. And you can add, if that fails, you can add fingolimod in the therapy. Highly active diseases, the second line oral agents like fingolimod, siponimod, or the infusions, natalizumab, cladribine, ocrelizumab, all the MABs can be used, including rituximab for most severe disease. In very severe progressive disease, which is non-responsive, we have aggressive therapy with cyclophosphamide, mitoxantrone, or autologous hematopoietic stem cell transplantation. So actually what has changed is really the approach to treating multiple sclerosis in that we look at this pretty aggressively, and every relapse is considered as a neuron loss episode. And the idea is to prevent relapses as much as possible to decrease the morbidity of this disease. As you can see, there are a number of clinical trials available, which have been either completed or undergoing for looking at various disease-modifying agents. So summing it up, pediatric onset multiple sclerosis is a rare but important cause of ataxia. It is often misdiagnosed at presentation. It is very important to recognize it early and give appropriate treatment. There are emerging therapies for disease modification which are available and should be given to decrease the morbidity and improve quality of life. Thank you.
Thank you very much, Dr. Sani, for the nice case. Once again, I would like to thank all viewers from Dubai, UAE, and other countries, 400 plus at this time. Really, this shows our speaker, how important are our speakers and topic. Keeping the people awake at this time is very, rare to find out 400 plus, especially in countries like India. Thank you very much, Dr. Aman. Now I would like to request Dr. Manoj to present the short case. Dr. Manoj is a consultant pediatric neurologist at Royal Hospital NMC at Sharjah. Dr. Manoj, are you with us? Mr. Tawfiq, Dr. Manoj has joined.
Yeah, he is there, doctor.
So, Dr. Manoj, please.
Hi.
There are so many questions to be discussed.
We cannot see you.
Dr.
Hello.
Manoj, please.
Yeah, we can hear you, but we cannot see you, doctor.
Yes. Welcome, Dr. Manoj. Please.
I thank you, Dr. Shorab, and thank you, Dr. My colleague, Dr. Sani, and Dr. Aman, and Dr. Saurabh. Hello.
Yes, doctor. So,
Share your screen,
Yeah.
Dr.
Can you hear and see my presentation?
no, not yet, doctor. We can hear you, but not your screen. Can you just click on share screen?
Today I forgot to thank our sponsor. Our sponsor is Vita Biotics, country business manager of that is Mr. Tofir.
Now, Tawfiq, you
I
can
really
see.
thank. Yes, please.
Yes.
Huh?
Yes, doctor. You can start the presentation. Yes.
Okay. I'll present a very small short case.
Dr. Manoj,
Yeah.
sir, if you can just adjust your camera a bit.
Okay.
Yeah. Okay, go ahead, doctor. Still your face is not visible. Half your face is visible only.
It's okay, Mr. Tofir.
Yeah.
Okay. Of uncommon condition with uncommon presentation. So we have a 10-year-old girl child who is pre-morbidly developmentally normal without any adverse parental event, school going, presented to the emergency department with history of difficulty in walking for last 1 day. She had fever for 2 days, received paracetamol 2 weeks before of this walking difficulty. There was no history of any seizure or any altered sensorium or any abnormal movement or any weakness of limbs, no sensory involvement, and clinical history was not suggestive of any bladder or bowel involvement. There was no history of any vomiting, any skin lesion, joint pain, any injury in recent past, or any intoxication. So on examination, child was conscious, oriented to time, place, and person, but little bit confused, with slurred speech. There was no cranial involvement, vitally stable. Motor examination, tone, power, reflexes were all normal, with bilateral plantar downgoing. There was no sensory involvement, no bladder or bowel involvement, but bilateral cerebellar signs were present. Spine examination, normal. So as already presented, is a case of acute ataxia. So we thought of acute cerebellitis with encephalopathy. Query etiology was infective or para-infectious or post-infective. Just reviewing the past history, child was admitted about 1 year before in different hospital with almost similar complaint, and at that time the CSF was done and so little bit higher protein and lymphocytes. So treated like a case of viral meningoencephalitis. Though HSV PCR and varicella IgM were negative and MRI brain was normal. And the child recovered almost completely in next 2 months. So keeping all the relevant present history with a significant past history, the child workup was started. CSF this time was normal with normal HSV PCR, varicella IgM were also negative. MRI and MRV both were normal. EG normal, and the autoimmune workup like NA, RF, NMDA receptor, VGKC, and anti-NMO antibodies, all were negative. The thyroid function test was normal. The anti-thyroid antibodies, anti-TPO levels were high. It was around 1100 against the normal upper range of 60. So the diagnosis of Hashimoto's encephalopathy was made, and patient was treated with pulse of methylprednisolone, followed by the oral tapering dose of steroid, and child showed remarkable improvement within few months, and her cerebellar signs also disappeared. So our learning point is that though Hashimoto's encephalopathy is an uncommon condition with wide spectrum of presentation, with a normal MRI, normal CSF, and normal EEG, and with maybe a normal thyroid function also, we should do anti-thyroid antibodies to rule out Hashimoto's encephalopathy, especially in a child who presenting with neuropsychiatric manifestations in pediatric age group like cognitive decline, depression, with or without seizure, and plus minus ataxia. So the learning point is the anti-thyroid antibodies should be done with a normal neuroimaging, CSF, EEG, and anti-autoimmune workup with such kind of skill test. Thank you.
Thank you very much, Dr. Manoj, for briefly describing this rare case. Now, I would like to request our moderators to prepare the question. We will have a very short video of 2 minutes.
No, we'll not. We can start directly the question and answer.
Okay, thank you very much. We would like to thank Mr. Tofir, the country business manager of the Vita Biotics, for sponsoring. Really, he is kind enough to allow us to continue. Now, I would like to request our moderators, Dr. Kalpana and Dr. Rafia, to start question and answer. And I would like to request our panelists, Dr. Santosh, Dr. Sani, Dr. Aman, and Dr. Manoj to join the panel. And there are a lot of questions to be answered. I would like to request the viewers to write their question in the question and answer box, so that I would like to give one announcement. On 15th of next month, Prime Group, they are having a conference, International Pediatric Conference. Dr. Rafia, our moderator, and Dr. Joshi, our past president, they are president of this conference. Please join them. They are very good speakers, and register, please. Dr. Kalpana, over to you. Thank you.
Thank you, Dr. Sahrab. First and foremost, thank you, Dr. Santosh Mondekar. It was an excellent presentation. And I thank the other 3 neurologists as well for their very interesting cases. We have lots of questions. We would like to combine some, and we will start off with the first question. Dr. Rafia, can you take the first question, please?
Good evening. Thank you very much for the very interesting questions, very interesting presentation today. Just there is very important question, and it is like a feedback. Just a feedback come from Dr. Kritsha. He is saying that it's excellent information, but how much useful for the pediatrician in day-to-day practice remains questionable. So we need them to point us along the direction of basic workup at our level before referrer, rather than talk about complex therapies and specialist workup.
Okay, so I think here probably you would tend to agree with us after listening to the detailed presentation on ataxia, it almost made me feel like we talk about PUO, fever being a symptom, and there would be so many different diagnoses, isn't it? So when we are talking about office pediatrics, I think Dr. Santosh, can you guide us? What would be few conditions that you would say we should never miss? And then couple of them that are easily treatable. If you can just give us those, because that is the first and foremost thing on our mind when we see a case of ataxia.
Okay, so if somebody comes with acute onset ataxia, the history is very vital, but any ataxia, you will need some kind of a neuroimaging to make sure it is not a space-occupying lesion. So that's one thing you should not miss. Then depends on the history which is there. So that's the reason I did not give a blanket set of investigations, because there are no blanket set of investigation, and I do not do them. So I will work around it. So if it's a toddler who has come in my mind, if the MRI brain scan is normal, one of the things to consider is toxicologies. So that I will think about. So I will plan. I do not do all investigations in everybody. We do not do, if I've said to you, it is rare. So in a ataxia clinic, when they come to me, they do not come. There are lots of general pediatricians in our region who are seeing acute onset ataxia, which they're managing themselves. If they need a follow-up, quite a few of them are transient and they will make a full recovery. So they do not need any further investigations. So you have to plan yourself what it is there. So if it is a vegan, if you've got something on MRI which shows white matter, then you're thinking of vitamin complex, B complex. Every ataxia does not need a vitamin cocktail. They do not need that. So you have to target your investigations. And in NHS, that is what is very good about that. You're looking at everything is evidence-based. So that's the reason of you're trying to understand. And quite a few are managed. They don't come to me at all. So they're managed by general office pediatricians in here, and they're settled. Those who do not settle are the ones which are called to me or referred to our neurologist for advice.
Sure. So I think on more than one occasion, you mentioned that it's a protocol to do toxic screens in all of them who present to your emergency department. So I'd like to just ask the other panelists, do we follow a similar practice here with their cases? So Dr. Sunny, maybe you can take this question.
I mean, in an acute presentation, particularly if there is a child who's encephalopathic and ataxic, the toxicology becomes an important thing. So neuroimaging, acute markers for infection, inflammation, EEG, and toxicology, those are ballpark the common investigations you would do. Quite easy to do and quite simple and can be processed in most ED departments nowadays.
Right. So
just I would like to add, in pediatric neurology, always is history added by examination is the key to reach or to diagnose the case. And we talk about, because we as a neurologist talk about rare conditions. So if acute, transient conditions, so many conditions are there who can be corrected, are diagnosed at the pre-neurologist level. Only the chronic or episodic ataxia or some acute conditions who need follow-up is the only area where really they need the pediatric neurologist.
sure. Rafia?
Yeah, there is one question for Dr. Sanchez. They are asking, would you recommend a cocktail of vitamin B and vitamin E in unexplained ataxia with normal basal workup before further expensive investigations?
Okay, so you do not, not in all of them if they're encephalopathic, first of all. The second thing is, again, you will see, so I don't know what happens in there. So for B12, you just need a urine investigation for methylmalonic acid. So that comes in UK in about a couple of days. So in 48 hours, you'll get it. And if you give it then, or if you give it late after 48 hours, doesn't make much difference. If you have taken the urine sample, if you're not sure, you can give it B12. So with the B12 levels, we'll get it on the same day in the UK. So B12 is that way. Vitamin E levels also, we get it in about 24 to 48 hours. So till then, you're only going to give it, if they're normal, you stop it. You don't need to keep on giving them, which is there. So you've got your levels. And they're normal. So you don't need to, it's not with, so I'm saying think of them because they're treatable causes. You will go down the tissue biopsies, skin and muscle biopsy, and you miss a simple thing. That's the reason you have to be there. So I've seen a few of them who have had that going on, and they were referred to me, and they were just found to have these simple things, and it was treatable. The child, I have a lot of videos of them, what they were before, giving vitamin B12, how they improved in 72 hours. But because I don't have the consent, I'm not showing those videos.
Then you mean after the result of the investigation?
You can stop it. I mean, if it's there, you can stop it. You'll get results very quickly.
Yes. Dr.
Okay. Yes, the next question, maybe Dr. Aman, you can take this. This is from Dr. Krishnamurthy, who's asking that some of the conditions like GLUT1 deficiency or other metabolic abnormalities, why do they present with intermittent ataxia rather than chronic, as they are present all through? So why do these present with intermittent ataxia?
Kalpana, I was hoping you will not ask me, but okay, if not, that you ask me, I'll answer this question. Okay, so it's a very interesting question, and you have to understand that GLUT1 deficiency syndrome, for example, it's a very heterogeneous condition. The transporter can be absent completely. The transporter can be absent, kind of deficient as well. So we had a very interesting case in Newcastle. I still always give that example, that this mother used to say, when I feed my child with Lucozade, my child stops having ataxia. We actually presented this case in the BAPNA meeting as well, long time ago. So because it's a very heterogeneous condition, you give them food and then there's a surge of kind of sugar and their ataxia gets better. And as they are kind of going past and going to a stage when they're starving after 3 hours, the ataxias, the dystonias, and other features of GLUT1 comes in. And hence the reason we always say, if you suspect GLUT1, make sure that you do the CSF when the child is starving, not after a meal. So that's your answer there. This is why they are intermittent, not constant.
Thank you. There's another question from Dr. Khalid that what percentage of children with acute ataxias remain undiagnosed even with extensive investigations? Dr. Santosh.
Not acute ataxias. I mean, that will go off. See, acute means you're going to say if they're persistent acute ataxias.
Let's talk about persistent.
There are quite a few, and a lot of things a lot of heavy emphasis is done on gene testing. Even with genomic testing, we know that only about 30% to 35% of them are still diagnosed positive. So you can have a gene negative ataxia once you've ruled out everything. So one thing which Dr. Rahul presented is very important. Again, Hashimoto's. We had a Hashimoto's encephalopathy child came in. She came in, it was diagnosed on the second or third attempt. She came in, all the investigation was done. She was sent home for recurrent encephalopathy. Again, she came in and we had all the workup which was done. And she had a very high dose of very high levels of thyroid and peroxidase antibodies. So sometimes you'll miss it, but you'll make a diagnosis. But there are quite a few which we don't know the diagnosis, and there will be some mild cerebral atrophy or something which comes in, and then you'll try and find out what is the cause. We don't find. I've got a family to see tomorrow who are coming to see. I've not found any cause in them. They started with acute ataxia. They're still undiagnosed. So quite a few of them we will not find a cause. So we are trying to find out if there's a treatable condition or otherwise the treatment is symptomatic, and therapy therapy plays an important role. That's what it is. So answer is quite a lot. So it's not that when you see an ataxia especially you get an answer. Unfortunately you don't.
I just wanted to add in, of course, I mean, going back 15 years ago when we started practicing as consultants, 20 years ago, a very large percentage of these children were undiagnosed. And we have become very sophisticated in our investigations, the complex investigations we do. And particularly in the last 5 years, the genomics have gone really exploded. And now we know that we used to be able to do small genomic panels. And of course, Dr. Santosh sort of referred to the Sheffield panel, which had 147 genes. We used to all send it to them when we were practicing. Now we can do whole exome sequencing, and even become now easily here, even in Dubai, we can do whole genome sequencing. So more and more, the percentage of children who will remain undiagnosed is becoming smaller and smaller, but they are still there. But,
Right.
you know,
So
it's-
that brings me to the question of how do you pick and choose which ones will go for the genetic testing? Because there in UK, I suppose the state pays for it. Here, the payment issue might be a big factor too, because insurances, I doubt, would cover that.
Yeah.
So
Again, Kalpana, the problem even here, it's not that everybody, at the moment, the genomic sequencing can be only ordered by the geneticist, and if they feel it appropriate, and pediatric neurologist. Nobody else can. So a DGH office pediatrician cannot order it. And that's the reason they're rationed. So my view would be that if you're thinking about it, you need to refer it to either Dr. Sunny, Dr. Rahul, or Dr. Aman. So they decide, because you will need a pediatric neurologist to decide. You don't want to spend the patient's money on, for any genomic. It is expensive, and every investigation should be valued. That and you have to try and be cost effective as much as possible. So my answer would be, ask them to be reviewed by either Dr. Sunny, Dr. Rahul, or Dr. Aman, or whoever your pediatric neurologist is, and they let them take that call whether it's required or not.
yeah, definitely. These cases would go to them before this decision is made, that no questions asked. They won't be done by the general pediatrician level most of the times.
Yes, Dr. Kalpana, I would like to add one more. That only the acute onset progressive or episodic versus chronic progressive. These are the category where we should be very conscious to diagnose treatable causes. First, our priority should be to diagnose anything which can be treated. Like Dr. Santosh told, vitamin E deficiency, some metabolic deficiency, where we can help the child and we can treat the child. Rest is only academic. We can do diagnosis, pediatric ataxia, ataxia telangiectasia, SCA, so many, there is a big list. But mostly we are treatment is supportive. So we should think of acute versus treatable causes of ataxia should not be missed in our day-to-day practice.
Yeah, sure.
There is a very important question for Dr. Sanuj asking what are the common post-COVID neurology complications?
Fantastic. I thought nobody will ask me that question, so I asked it. I'll tell you, it's a new illness, okay, condition. So in UK, what we have got is we have got a different way of collecting the data for them. So there is one call is a BPSU, that is British Pediatric Surveillance Unit, and there is one thing on behalf of BPNA, so BPNA Surveillance Unit. So Rachel Neen, Evangeline Wassemer, whom Sunny used to work with, they're collecting the data. So we don't know. So what you have got any child with COVID positive who has got any neurological complication or presentation, you have to report them, and then they're collecting the data. That data is still not out. But when I spoke to Dr. Wassemer just last week about some other patient, it is coming out there on the verge of publishing it. So not all of them just get ataxia per se, but there's a wide variation of neurological presentation. So you have to collect everything. So tremors, if are there, fatigue, weaknesses. So you have to report. So then the report will come that, see fatigue, weakness on one side, tremors was seen in 30%, 40%. So that's a whole NHS England based collection which is going on. So
but no ataxia, no ataxia.
There are people, because I'm not the part of that group, I haven't seen anybody with ataxia who is COVID positive. But the problem, what happens sometimes is if you have got COVID and if you get some weakness gives you to lead to ataxia. There was one question I saw, somebody said, what is the mechanism of spinal muscular atrophy causing ataxia? So weakness can make you, if you're weak, it appears ataxic. So any of the neuropathies, I've got a few who were referred to me as actually ataxic, but they were actually CMT type 1. So you can get weakness can mimic as an ataxia. So you have to be very careful about those things. But as far as I know, the results should be out, and that should help answer the question about the COVID presentation specifically as an ataxia. But there's a wide range of presentation of that.
Sorry, I'm interrupting. Recently, Medscape, just a few days back, they published one article, the seizure as a first manifestation of COVID in children. One paper was published in children, seizure I have put it in Dubai Pediatric Club Facebook. Yes.
And
No, as
Guillain-Barré,
in
there's been a few reported Guillain-Barré.
Yeah, Guillain-Barré. I was about to say the Guillain-Barré is there, but that is, you know, any para, it's like a para-infectious cause, and any the virus will attack you.
Absolutely.
That's correct.
Dr. Sunny, in your case, the child had presented in January 21 also, before you saw the child in May. So going retrospectively, would you think that that was a reasonable diagnosis that was made at that time based on the clinical presentation and the MRI that was available?
So,
or was there any way to suspect MS?
I think one of the difficulties in neuroimaging is who reports the neuroimaging. And that neuroimaging was clearly underreported because there was the cerebellar peduncle lesion there already and the brainstem lesion there, in addition to the one in the left parietal lead. So that was not reported. So if that was reported, the stroke would have gone out, because you can't have a stroke which presents with supratentorial and infratentorial, and then you have multiple locations that makes demyelination much more likely. So I think one of the difficulties is when scans are not reported and they're reported in a certain way, you come to a diagnosis. And if your clinical presentation was weakness and you find a lesion in the parietal lesion in the region, you could conclude that was a stroke. But I think if you looked at the scan, the other lesions were visible retrospectively, I could see it.
In the same case, a couple of other questions that arose were the importance of the neurofilament light chain. Is that to be taken as a very diagnostic test? What is generally the incidence and prognosis of MS in children, and the cost of treatment that you put the child on, the disease modifying drug?
Okay, so the sensitive, I mean, we do a range of antibodies within the CSF when we look at any demyelination, most common being oligoclonal bands. But nowadays we also do MOG, NMO, because these are other conditions, neuroinflammatory conditions which present, and the treatment profile and the prognosis is very different. Neurofilament light is very sensitive to acute neuronal damage. So if you have oligoclonal bands and neurofilament light, then you've got significant evidence of neuronal damage happening and inflammation happening. So that just picks it up. So I think it's a very sensitive, it's available nowadays, and you can do it quite easily. The incidence of pediatric MS, as I said, is not common. It's rare. It's up to 3 per 100,000. But when they do present, it's a difficult condition, and because of the rapid relapsing remitting condition, and because it's progressive and you lead to loss of neurons every time you present, it becomes an important part to recognize and treat aggressively. Because you're saving the brain every time by disease modifying, you're preventing brain damage, you're preventing neuronal loss. So that's quite important. Now, the cost of fingolimod, I could tell you, it's 25,000 dirhams for 2 months. So 12,500 dirhams per month, roughly, in a adolescent and adult. So these therapies are expensive, but they are covered by insurance. And then there is a society in UAE which will charitably also support the cost provision if the patient can't provide for them. So there is a supportive society which does help.
Right.
Can I just come in there as well, Kalpana? So
yeah, sure.
These disease-modifying agents, DMAs as we call them, so they have moved on, as Dr. Sunny said, over the past 10 years or so. And recently, we also have something called the ocrelizumab, the Ocrevus, which Dr. Sunny was mentioning too. Now, this Ocrevus, the beauty of Ocrevus is that it is given once every 6-month infusion. So I have a patient right now who's a 14-year-old boy who would not take oral fingolimod, who would not take daily injections. So we put him on 6-monthly Ocrevus. Hopefully, we're going to be publishing it soon, and he's doing fine. Touch wood over the past 1 year. So the DMAs are moving on as we are seeing, and there'll be lots more coming through. And if you look at the disability kind of score, as we call it, the expense of the medication as opposed to what the MS causes disability, it's far less when we talk about the medications as opposed to their disability.
Sure.
Also, if you're preventing relapses, the cost of admission every time a child gets admitted is like, 3,000, 4,000 dirhams every day, plus therapy, plus rehabilitation, plus the distress and the inconvenience to the family. So there's a huge cost attached to that.
Absolutely. Absolutely. Yeah.
And these
Yes.
therapies are tailored, as Dr. Mann said, individually to each patient. Some would like injectables, some like oral medications, some like infusion. So you really have to have a detailed discussion with the family regarding the suitability of one or the other for each patient. So there's a menu, and that we are quite fortunate that we have now the availability of multiple agents. Previously, about 10 years ago, we just had interferon and Capoxon, so quite limiting.
Yeah. Yeah, actually looking at the chart that or the table that you presented, Dr. Sunny, I think I need to go back to pharmacology because these things were non-existing then and it all sounds like Greek and Latin to us now. So unless we are into it and keeping in touch with it. Yes, Dr. Afia, you can go ahead with
Yeah, there is one question from Dr. Wiam to Dr. Minoksha. Do you recommend the thyroid antibody to be done to any case of ataxia?
Dr. Manoj, for his case?
Yeah, yes.
Yeah. Not in each and every case. If clinically justified, like in my case, it was a recurrent acute ataxia with normal EEG, normal neuroimaging, normal autoimmune workup, normal everything. Then, and the clinically child is we suspect, then we should go for thyroid function test, even though we can have normal or hypo or hyperthyroidic thyroid status, but anti-thyroid antibodies are to be done in this scenario, not in each and every condition of attack.
Just to put the diagnosis that it is referred to the thyroid.
Yeah. So even though Hashimoto thyroiditis can have euthyroid and hyperthyroid and hypothyroid, any state can. Like my child had normal thyroid function test with high anti-TPO antibody.
Okay. Dr. Kalpana?
I think that also answers Dr. Atif's question, who wanted to know why the thyroid function was normal in that case. So as you mentioned, it could be euthyroid, whichever.
And in more or less in Hashimoto's encephalitis, it's not the antibodies are not correlated with the severity also. Still we are going on. We don't know if pathophysiology is unexplained, but it's a research that some other autoimmune antibodies doing something in the brain. It's not the anti-TPO which is harming the brain.
Right. So coming to Dr. Aman's case, there's a question, Dr. Aman, what actually causes obsoclonus myoclonus? What is the pathogenesis of that? If you can explain.
$1 million question. What causes OMA? We don't know. It's thought to be a neuroinflammatory condition. So as we know that in kids who have neuroblastoma and adults who have small cell carcinoma of lung, it's thought to be a paraneoplastic condition. And that causes neuroinflammation, and that leads up to OMA. But many of our cases we have which are non-neuroblastoma, and we look for it, but we don't find it. In those, we think it's an autoimmune inflammatory condition which affects the central nervous system as a para-infectious or post-infectious phenomena causing it. I don't know what the exact cause it. I think in future we might find an antibody causing OMA, like we are finding every day. We are finding new antibodies, and for example, Dr. Sunny mentioned about MOG antibodies. So maybe in future we'll have an antibody which causes OMA, but for now we just think it's a para-infectious, post-infectious, post-inflammatory autoimmune condition when it is a non-neuroblastoma, non-tumor.
Okay.
But one question, you gave IVIG and this thing for that child. Can you explain on that? I mean,
So same principle, Dr. Saurabh. So as I mentioned to you before, that if you suspect OMA, so that's one take-home message for all pediatricians. If you think the child has got OMA, which is irritability, and you see the eye movements or tremulous or ataxic, this child needs to be sent over as soon as possible, because early treatment, early aggressive treatment has shown to be having better outcomes in OMA as opposed to those children who get treated late. Number one. Second thing is that you want to hit the child with immune kind of suppressive drugs as much as possible, as soon as possible. So we went straight with methylprednisolone and IV immunoglobulin together to see if we can get a better response. Now, Dr. Santosh is sitting here. He knows that they use the dexamethasone protocol, which I do apologize to him now. I did not use that protocol. I went for the IVIG methylpred followed by rituximab. So it's all about giving immune suppression as much as possible, as aggressive as possible. In Birmingham, we used to actually give ACTH injections to begin with. But over here, where I work, we don't have them. So we went for this particular kind of protocol.
Thank you.
Yeah, I have also one question to Dr. Amin. Would you not include enterovirus PCR in your viral panel workup for the case described? Would you do an echocardiography to rule out an unlikely possibility of Kawasaki?
Yeah, so the answer to your first question, yes, the panel did include enterovirus. I only put the main ones, which are more neurotropic viruses. So I just put them in the slide. I did not put the other ones, but you're right. Enterovirus is a part of our panel, particularly if we have a child who's got acute cerebellar ataxia. Enterovirus PCR is very important in them as well. Sorry, the second question was, I just missed that.
About echocardiography to rule out atypical Kawasaki.
In this particular child, I can't remember whether echo was done, but you know, doing echo is no harm, because if you suspect the child is going towards Kawasaki and you've got the features of Kawasaki, this child did not have features of Kawasaki, by the way, but if you suspect that the other features of Kawasaki are there, then there is no harm in doing a quick echo to make sure the coronaries are okay. But I don't remember whether in this child we did an echo or not. But by kind of, if you think it's OMA, you need to look more for neuroblastoma rather than worrying about the heart there. But again, if you're thinking on lines of Kawasaki, of course, do an echo as well.
Now, because nowadays we have there is a lot of discussion about MISC, and this MISC come after COVID, and it can come with this neurologic complication. So when you spoke about the treatment, the people maybe thought that we are putting the same protocol actually.
Yes, you're right. So again, it's the using immunosuppressive medication there. So I agree with you, because of the post-COVID, you know, MISC is a major kind of thing which we look into pediatrics, and that's why echo is very important. I will add to, I was quiet when they were talking about the post-COVID kind of things in children and neurological complications. I have had cases with which Dr. Sunny was mentioning. We have seen Guillain-Barré. We've actually also seen a basal ganglia stroke post-COVID as well. So these things do come up, but they're fortunately rare in children as opposed to adults. But you know, when you suspect MISC, by all means, echo is a very important part of that investigation.
One thing I wanted to add in obstructive macula, very eloquent case, of course, Aman. Nowadays, you know, the difficulty we have in chasing neuroblastoma, doing MIBG scans or doing VMAs, and you know, trying to sample urine 24-hour spot. Nowadays, you have the availability of something called dotatate PET scans, which is very eloquent in picking up neuroendocrinal tumors. So, and it's much more sensitive than MIBG. So we, like here in, you know, Mediclinic, we would do dotatate much more quickly, and it's a whole body scan. You can do it very quickly. So it's become easier in terms of trying to pick it up.
Yeah. Dr. Aman, in your case, after extensive workup, neuroblastoma was ruled out. So I wonder whether this child still needs to be followed up. Could he still develop a neuroblastoma, or we take it as one of those OMAs that did not have a neuroblastoma?
So the answer to all of your questions is yes, Kalpana. So yes, this child needs to be followed up very carefully. In fact, the hematologist is going to see this child regularly along with us. We did discuss something called occult neuroblastomas. And as Dr. Sunny was saying, that the scan is very good at picking up occult neuroblastomas, because MIBG is not very commonly kind of found as investigation unless you're in a big hospital. So yeah, this child will be serially followed up to make sure this child doesn't develop a neuroblastoma in future. And from neurology point of view also, we're going to see this child regularly, whether this child needs further rituximab. There are times when they need more infusions. So far, this child hasn't come up with so all the investigations have drawn a blank. So at the moment, we're calling it a non-neuroblastoma OMA for now.
Okay, thank you. Dr. Mordecai, there's a question from Dr. Khalid regarding the incidence of lead poisoning and ataxia. How common is it?
I saw that. I mean, I frankly don't know much about it, because in UK now the lead pipes are not there unless you're in the very old buildings now. So I don't know. The reason I was saying was this is one of the things you need to look out for, but it is increasingly become less and less now. So in the ataxia group, which I have seen, I've been doing the ataxia clinic now for the last about 4 or 5 years. Before that, Peter Baxter used to do before me. But I used to work with him, and we used to, for the last about 10, 15 years, we haven't found anybody, touchwood, in the UK with a lead pipe leading to an ataxia, this thing here. And lead pipe, poisoning or something has got a varied range of presentation. So they will have other markers as well. So they'll have anemia, they'll have something else going on. So you will be picked up. So usually it might happen that rather than me picking it up, some other general pediatrician picks up with some other presentation and comes in. But I haven't seen anybody so far in the last about 10 to 15 years as lead poisoning leading to an ataxia, really.
Okay. Rafia?
Actually, there is one question about what is the role of ultrasound brain in identifying space occupying lesions? What is the role of ultrasound brain in identifying space occupying lesions? This for Dr. Soni.
So I guess ultrasound of the brain can be done only in children where you have access to an open window. So if your anterior frontal is open, that's probably an easy investigation to do as the first line. To pick up ultrasound is good to pick up lesions, good to pick up hemorrhages or bright signals, but it's not the gold standard.
Okay.
So it's not the gold standard. So if you have a negative ultrasound, doesn't mean that you don't have a lesion. If you still suspect, you would go ahead with the imaging, MRI imaging. But it's in a young neonate with an open anterior frontal, it's easily doable as a first line.
Less than 6 months till infants, less than 6 months, okay?
Yeah, but don't take a negative result as a comforting sign if you've got persisting symptoms. Yeah.
There's a question from Dr.
Well, I think ultrasound scan depends upon who does it. If I'm the person, chances is 0% of getting anything. So if it's a very good radiologist, they will pick it up. And I always feel the posterior fossa, unless you've got a posterior frontal open, you might miss it quickly. So what Sunny said is absolutely right. If you get positive, brilliant. But if you get negative, don't exclude. That doesn't mean it's excluded.
Okay. Dr. Sanjay Udani wants to know that ataxia being so common with various etiologies, are there any particular associated symptoms, signs, or features when an acute ataxia is due to drug intoxication or withdrawal? Both infants or kids due to accidental overdose or teens in voluntary administration of narcotics do present. So,
no, I mean, there's no other specific sign. It's a history. See, the history will tell you that. If there's a history of, say, mental health issues, then you're going to think about whether it's there or not. But if it's there, it can happen accidentally. Teenagers will go for, first night out with friends. Something happens, substance misuse. So, I'm not talking about ataxia. In cases of acute encephalopathy in any adolescent, young man or young girl, if they got acute toxicology is one of the common causes. If there is no infection, there is nothing in the history, you'll have to always think for. And unless you look out for it, you're going to miss it. So it's just the history. So lack of history doesn't rule it out, but there's no specific marker or specific point on it, really.
There's a comment from Dr. Krishnamurthy regarding vaccines and ataxia. And he points out that this is basically seen with influenza vaccine and anti-rabies vaccine, not commonly associated with other childhood vaccines. So have you come across any other vaccines and ataxia in your practice?
No, ataxia, I mean, that led to GBS causing ataxia. So I've seen a few in girls with HPV vaccine, which they give it to teenage girls, which we give. I've seen a few with them. Had a HPV vaccination, and 6 weeks down the line, they've got it. But otherwise, not so much which could be related to vaccine. So it's just an autoimmune response to that. So some people get it, some people don't get it. Take your point in rabies. I've seen a few in India with GBS presentation. I've seen them. So otherwise, I haven't seen any specific that other vaccines. So Dr. Krishnamurthy may be absolutely right in that.
Okay. You also spoke about the rating scale. I just wanted to know, is that specifically for your research purposes that you use it?
No,
because they were very extensive.
It is research, but I like to use, but it is used for a progression of ataxia. It's a good marker. So it is used for it. There are different scales, as I said. So I use SARAS because it's widely used in UK and European population. It's easy to do it. It just tells you with that. There are publications, as I said, so under 7 or 8 years of age, if you look at it, it might be difficult to distinguish between them because you need a lot of cooperation, standing still if they're walking in a straight line, so it is there. So there is a lot of papers published on the validity of SARA scale and its interpretation in under 5 and 6 years of age. But overall, 8 to 11 years of age, it is there. So one of the studies which I'm contemplating is trying to look out for it in what is the variation is in doing a cohort of going to normal school, doing about 50 children, 50 of my referred to ataxia, what is the validity of it, and say 15 any say celiac, because the thing I didn't talk a bit about was which I'm gluten sensitive ataxia. So I'm just about to publish a case series of 8 children, just sending to EJPN. We've just finished in it. So are there any identifying markers with that? So at Sheffield, in the my adult neurology colleague, Professor Marius Hadjivassiliou, so he's a big time, he's done a lot of research on gluten sensitive ataxias. And he told me that when he sees them, by the time they reach him, they have already developed neuropathies. And because they have developed that, it was a preventable cause, but interestingly, they did not have the abdominal celiac. So there is a group of them who can present with a non-abdominal symptom celiac disease. So at Sheffield, what we have is we have got a TG6 level. So we do transglutaminase 6 levels. And if those are high, and we match with antigliadin and anti-endomycin, which I picked up in these 8 children, they did not have any abdominal features of celiac at all. So they were completely well because they came positive. And this was, we were trying to look out for it. Whether these, because he said that to me, a lot of came negative, so quite a few came negative. So which they came back, and then when we went and looked at it, and putting them on a gluten-free diet, what we have done is I've done MR spectroscopy of the cerebellum as a baseline, and that was abnormal. Now we have put it on that, and we have for a year now they're on it, and a year later we're going to see MR spectroscopy, do the spectroscopy markers improve or not. So that's a good identifiable marker, and plus the clinical symptoms, the SARAS improves or not. So that is the study. We are just about to publish a retrospective cohort, and now prospectively we'll publish probably next year on that.
So did any of these 8 children undergo biopsy along with the markers?
Yeah. After they came
they were
positive,
all negative.
The abdominal symptoms, 3 of them came, I mean, I can't remember the grading of the celiac. There's some grading scale, which is 3 of them came grade 3. 2 of them came from grade 1, very mild, and this is questionable, but our gastroenterologist said that since you've got TG6 positive, we might as well give it. There's no harm in giving a gluten-free diet for a year and see, and monitoring them and see. So we have done that. So, but otherwise they were not that, which you see like low-grade anemia, that was not there. The weight loss, fatigue, tiredness was not there. So that is one thing which is there, but you have to use it with caution because you don't want to start doing everybody for this. So it is not. So we're trying to understand what it is, but there are quite a few adult neurologists. What had happened was the mother or father had that, and the son or daughter had the symptoms of slightly, and they were labeled as dyspraxia and clumsiness with the community pediatricians here. So the professor Hadiji Vasan said, why don't you do it and see if it's positive? And because his lab currently does it for research purposes, so we just did it, and they were positive with the mother, father. That we picked up. Now we don't know what is the incidence. Say in general population, do all dyspraxics need to have it? No, because dyspraxia is common. But the sore throat is common. Things are common. You can't go for the first rare cause for that, and that is where it is. So we don't know much about it. It's just an evolving picture.
Absolutely. But did the thought of gluten ataxia start in these familial cases? What was the thought? How did it
Also,
come about?
the few were picked up by these with this familial cases, and few even the parents were just picked up some by a rare thing, like one of the EEG technician just went for a control for max stimulation, which was doing, and it was grossly abnormal. And then she was found to have it. Then her son and daughter have got it. So I've got those now positive, and they were just slightly tired, but they thought that they were teenagers, both the children. They thought they're just teenagers playing up, tired, growing pains, etc. They had it. But suddenly when I put them on it, they've really now become energetic, and they have now started to do PE, play, football, suddenly is improved. Now we don't know what it is. Was it by pure chance we picked up? We don't know that. So it just needs a bit of a more workup to be done on it. But otherwise, we don't have clear identifiable markers at the moment. So that probably will either this year or probably next year EPNS will present it.
But I would like to request, we'll go 5 minutes more, because here is midnight, in India is 1:30 morning almost.
Yes, doctor, I think we have practically gone through most of the questions.
I wanted to add one thing. The video you presented about the functional ataxia, very beautiful video, Santosh.
Yes.
And it shows the very classical sign of what we call labile indifference.
Exactly. I didn't want, because then I knew that, yeah.
Or what's called beautiful ignorance, and that the child looked hugely ataxic but was smiling and happy. And that's a very classical sign in that.
So always the smile is always there. See, if you're that kind of a thing, they're worried they're going to fall. It was not there. That's always, but I didn't want to go down. That's mostly in functional neurology. So to be very careful about expression. This is very important. And again, I'm just digressing now, but if you want audiences, there is a lot of work done by John Stone, who is a adult neurologist in Edinburgh, and it's called neurosymptoms.org. So if you go on that website, every functional neurological disorder, there's a functional weakness, functional ataxia, functional tremors, how to tackle it, what is the mechanism. It is an adult base, but it really, really well written. And it's www.neurosymptoms.org. If you go on the website, it is really phenomenally written. And that's all these what studies, labels and sign, everything is there, what it is, how to diagnose functional neurological disorders, everything is there.
So, like I said, I think we have gone through most of the things that a general pediatrician should remember as far as acute ataxia, intermittent ataxias, and chronic, which are important, how to think about it, what is our diagnostic approach. Just a word I would like from you on benign paroxysmal vertigo, because this is one of those conditions that comes up to a general pediatrician and we should be able to pick up. So I know you touched upon it, but maybe Dr. Sunny or Dr. Roman, one of them can. Tell us about
Dr. Aman.
Thank you. Nicely dodged towards me. So BPV, or so one thing which Kalpana, which always we were taught as residents, is to make sure there is a difference between BPV and BPPV, benign positional paroxysmal vertigo and benign paroxysmal vertigo. So I'll just remain on benign paroxysmal vertigo because there's a different topic altogether. So it's thought to be a migraine variant, basically the BPV, and I usually, when I see a child or a young person who comes to me with a sudden onset vertigo of no cause, and I'm assuming that we have done all the investigations to rule out cerebellar tumors or tumors in the brain and other causes for vertigo from ENT point of view. And then you go to the next question, is there a strong family history of migraine? More often than not, there is. Somebody in the family will have a strong history. And again, as everybody has mentioned in neurology, it all boils down to the history when you take from the patient as well as from the carers. and that's what makes the diagnosis. And they're very sensitive to treatment, just like migraine. So you start them on, there are different kinds of treatment, which I will not go into because it's a long kind of night now. But once you start treatment, you start to see the effect. And in my experience, most BPVs, it's very rare, by the way, but the ones which you have seen as they grow into adolescence and adulthood, they get better, just like migraines also improve with time. BPV also improves with time. Thank you.
Thank you.
There's a beautiful maneuver called Epilepsy maneuver, which you have to get your ENT surgeons in tune with. If you suspect somebody has a cannulate which is causing BPPV. So sometimes it's very useful to get ENT surgeons with their opinion on this.
Right. So Dr. Saurabh.
Thank you very much. I'll give one announcement. After that, I would like to request the panelists to give their final remarks. After this, since everything is opening up, we will have our meeting once a month in the, as a physical in the hotels. Once every month or once every 2 months, we'll have a high standard webinars with good speakers like Dr. Santosh. So we'll follow that. I would like to thank Dr. Santosh, Dr. Sani, Dr. Aman, Dr. Manoj, Dr. Kalpana, Dr. Rafia. Once I would like to thank all viewers, 300 plus is still midnight. They are following us really. This is amazing. It shows that how important is neurology and how important our panelists are. I would like to thank all of them. Now I would like to request, once again, I would like to say on 15th of next month, there is International Pediatric Conference. Please register. Dr. Joshi and Dr. Rafia are there. And now, Dr. Santosh, please, your final remarks.
First of all, thank you very much for asking me to talk on this subject. I'm very passionate about it. And it was a pleasure having meeting with Sunny and Aman, are very close friends. Pleasure meeting with them. Kalpana and we are trained in the same medical school in Mumbai years back. So when she asked me, I just grabbed the opportunity with both hands. So it's been a real pleasure, and I hope it was helpful. And I'm also thankful for, as you said, 300 people or 300 delegates still being awake at this time. I would struggle to keep myself awake because in UK, it's a much, the better time. It's evening at 8 o'clock, 8:30 now, or 9 o'clock now. So it's a much more sensible time. But thank you very much for asking me. It's been a pleasure to be giving a talk.
Sunny, please.
And thank you, Dr. Saurabh. That's you, Dr. Kalpana and Dr. Rafia, very amazingly organized, and Tawfiq. Pleasure to be here. Thank you. And thank you for 300 people watching and listening at this time of the evening and night, midnight, and of course it's 1:30 in India.
Dr. Aman, please. Dr. Aman.
Dr. Aman.
Dr. Santosh, thank you very much for joining in. It's really nice to see you after such a long time. It was an amazing talk and a good refresher for me as well to go through all those ataxia cases, and all the people, all the delegates who are listening. Again, we can't thank you enough for being up so late. I was asking Dr. Saurabh, who's going to listen to me at 11 o'clock at night time? And he said, just hang in there. There will be people listening to you as well. So thank you very much. Thank you, Kalpana. Thank you, Dr. Rafia. And Dr. Saurabh, thank you very much. Tawfiq, once again, thank you to you as well for organizing it. It was an amazing night. Thank you all.
Dr. Manoj,
thank you very much.
I'd like to thank you, everyone, organizer as well as the guest speaker, Dr. Santosh, Dr. Kalpana, Dr. Saurabh, Dr. Rafia, and two of my colleagues, Dr. Sunny and Aman. Thank you very much.
Thank you, Dr. Kalpana. Yes, Dr.
I
Sunny.
think Dr. Sunny wants to say something.
Yes,
No. I was just saying thumbs up.
Okay. So it's been great listening.
Also, that is remaining.
Yeah, sure. It's been great listening to you, Dr. Santosh. It was really very informative talk, and I must point out that Dr. Aman has twice been voted as our star speaker in DPC conferences, and now he's got you as a competitor. So we will definitely be looking forward to having more talks with you. Thanks, Dr. Sunny and Dr. Manoj.
Dr. Santosh, don't worry about it. I'm no match.
Pleasure.
And thank you to Dr. Sunny and Dr. Manoj as well for their very interesting cases. Dr. Sohrab, as always. And without Tawfiq, these meetings are not possible.
Yes,
Thanks,
yes.
Dr. Rafia, for helping me in moderation.
Thank you.
Okay,
Thank
yeah,
you. Thank you very
also.
much.
Thank you. Good night, everybody.
Thank you and good night, everyone.
Bye-bye.
Bye.